Welcome, everyone. Thank you so much for joining us tonight. My name is Samantha Banerjee. I'm the Executive Director of Push for Empowered Pregnancy, and I am very excited tonight to be joined by one of our medical advisors and board members, Dr. Harvey Kliman of Yale University, and one of our Changemaker volunteers, Jennica, Hugo's mom, who also volunteers with our close partners, Measure the Placenta. So we are here tonight to share about some exciting news that happened this week. This week, about over 50 stillbirth advocates, bereaved parents from around the country were in Washington, D.C., walking the halls of Congress, meeting with representatives, and celebrating the second National Stillbirth Prevention Day, which was passed as a resolution in both houses of Congress on Tuesday, September 19th. And other exciting, yes, that is huge. That's only the second time that has ever happened. Last year was the first time. And so really, really incredible way to get the eyes of those in power to focus on stillbirth and stillbirth prevention specifically. So we're really excited about that. And another thing that happened on Tuesday, September 19th, which we were also very excited about, is Dr. Harvey Kliman had some new research published. And so we have him here tonight to share with you about what exactly the research is, what the major findings are. And Jennica, as a lost parent like me, is going to share her son Hugo's story and the story of her subsequent pregnancy, and how the research that Harvey is doing is actually directly impacting real parents and real families and helping more parents and babies to make it home safe together. So thank you so much for being here. If you are watching on the Facebook live stream, you can drop questions in the chat and we will do our best to try to monitor and answer those. We're going to start with kind of just some introductions and giving you the main highlights. So Harvey, Dr. Harvey Kliman is a placental research scientist at Yale University, and he is one of the most preeminent placental scientists and researchers in the country, if not the world. And his new paper was just published again in the Journal of Reproductive Sciences, I believe it was called. So Harvey, I'm going to pass it over to you to give your full intro and tell everybody a little bit more about the research.
Sure. So first of all, thank you for having me, number one. Number two, for anybody listening who's had a loss, I'd just like to express my deepest condolences for your loss. My goal is to help families understand why losses occur. And that was actually the basis for our research. So many families are told, we don't know why you lost your baby. And it's not just frustrating, it goes beyond. The goal is to help families. It leads to feelings of guilt in the family. Mothers often feel that they must have done something wrong to lead to the loss. And to basically show them scientifically why the loss occurred so they understand that it wasn't their fault, I think is a very important responsibility that I have. I'm a physician scientist at Yale University, an MD, PhD in the Department of Obstetrics, Gynecology, and Reproductive Sciences. I do basic research on the placenta, but because of my research on the placenta, I'm in a position to help families and physicians who want to understand why their patients had pregnancy losses. The number one place to find an answer for why there was a loss or a complication in a pregnancy is looking at the placenta. And there are just so few people who do that. So one of the pushes we are trying to have here is to actually train more people. And that is what the SHINE, the law that is trying to be passed related to SHINE is to basically get money so that we can actually train more people to look at placentas. In the meantime, the paper that we published coincidentally on the same day as the National Stillbirth Prevention Day, and I planned it that way, was a study of looking over 1,000 patient losses between 6 and 43 weeks of pregnancy. There were almost 800 miscarriages, which is defined as a loss less than 20 weeks, and almost 400 stillbirths, which are losses at 20 weeks and beyond. And what we found is that the number one cause for stillbirths was a small placenta. And luckily, we have a tool now to actually measure the placenta using something called estimated placental volume with a very simple two-dimensional ultrasound technique. So really, we estimate that if we would use estimated placental volume routinely, we could save up to 7,000 babies a year, which is a big number. So that is one of our agenda items here, and we're trying very hard to try to get that in practice. The number one cause for miscarriages are genetic reasons, up to 90%. And we are at Yale and other centers. We're actually doing very detailed genetic studies on those losses to try to figure out the genetic basis for those miscarriages. So that's an overview of the paper that we published on Tuesday. And as I said, my goal is to help all families that have had problems with pregnancy losses. And people can email me at Yale at my name, harvey.kliman@yale.edu anytime. If they have a loss that they don't understand why, please email me and we will help you figure out why it happened.
Thank you so much, Dr. Kliman, for that detailed introduction. I have been, while you were speaking, I've been dropping some information into the chat on Facebook, including the link to the direct the journal article for anybody who's interested in reading it. It is open access, so you do not have to subscribe or pay. You know, we all feel really strongly that stillbirth prevention information and stillbirth diagnosis information does not belong behind a paywall. The parents deserve answers, and every family deserves to be empowered with the latest research. So thank you, Harvey, for making sure that that would be accessible to everyone. I've also dropping in the chat right now, Dr. Kliman's email address. You can contact him directly with any questions. Jennica, I'd love to turn it over to you now to introduce yourself. And if you don't mind, to tell us your story about Hugo, what happened with his loss, and share a parent's perspective of why the work that Harvey's doing in this research that was published is so important.
Sure. Hi. Yeah. Thank you for having me. I feel really honored to be here because Dr. Kliman's research absolutely changed the course of my aftermath, I guess, of Hugo's loss. So my first baby, my son Hugo, was stillborn at 39 weeks gestation on October 21st, 2021. Hugo was breech, so I had been really worried anyway about that. And I had just transferred to a new OB because I was supposed to give birth at a birth center. And the day before Hugo died, I was at the OB's office meeting him for the first time. He looked at Hugo and everything was fine. That night, I remember I slept way too well. I woke up in the morning and realized I hadn't felt Hugo move. The night before, he had moved pretty frantically, but that had happened before. So I woke up and I hadn't felt the baby move. I called the OB's office. They told me to wait a couple hours, to drink something sugary, to move around, all of that kind of stuff. I did that. And then I thought I felt Hugo move. I called again. They told me the same thing. So I waited, I don't know how many hours before actually going into the OB's office and finding out that my baby had died. As anybody who's experienced a loss knows, it's the worst moment of your entire life. And, I went on to deliver Hugo and he was born the next day. And after the loss, of course, the first thing I said was, what did I do? What did I do? Like most moms do. My OB told me, oh, you did nothing wrong. He was very kind in that way. He said, it's not your fault. It's not your fault. But what he also said was that it was probably a fluke, that, most people never find out what happened. I think he said 2/3 of stillbirths go undiagnosed. He told me, we did end up getting an autopsy, and he told me, you probably won't learn anything from the autopsy. That's what he told us. And after we did get the autopsy back, there was nothing on there. Actually, the OB said at I think it was my 6-week appointment, nothing exciting are the words he used on the autopsy, and he said something like, a healthy baby? And I was like, well, obviously not, because he died. So I was, not sure what to do with that information, but he told me it likely won't happen again, so try again and it won't happen again. And of course, everybody knows it's not that simple. This is your child that you've just lost. So it's not like, oh, just try again. We all know. So I sort of went on trying to just grieve and figure out my life after losing my baby. And I thought, I just won't find answers. I guess that's just how it is. Then I actually talked to a friend who had had 2 stillbirths before, and she was kind of my lifeline at the time. And she told me about Push for Empowered Pregnancy. And I'm so grateful for her, because I had actually gone off social media. So I hadn't seen anything about stillbirth on social media. And I went on the Clubhouse and listened to one of the episodes with Dr. Kliman answering questions. And I think the episode was called like, how do healthy, low-risk pregnancies end in stillbirth? And I was like, I want to know, because my pregnancy was completely low risk, minus breech, which had nothing to do with Hugo's death. And it had been textbook throughout my pregnancy. So I had no idea what had happened. So I listened to the episode and I found out there could be all these reasons why Hugo had died that I had never heard of before, that my OB had never talked about. So after listening, I was re-traumatized by realizing that I could find answers and I didn't know that. And what if I hadn't listened to this Clubhouse and didn't know I could find information? So I reached out to Dr. Kliman and he emailed me back so quickly, which I was so grateful for, because at that point I was just at the end of my rope. And so I had Hugo's placental slides sent to Dr. Kliman. And it was great because his assistant will help you with that process, because obviously it's very hard to reach out to the hospital where, you left your baby and never got to see them again. So once I got the results back, I actually found out that Hugo's placenta was in the 0.99 percentile. And the ratio between his body and his placenta was 30-1, which it should be 6-1 in a healthy pregnancy. So when I found that out, I knew what the reason was. And then I actually got on a Zoom with my partner and Dr. Kliman, and we found out that Hugo's placenta was small because of a genetic reason. So it could recur in a subsequent pregnancy. Fast forward, I got pregnant with my second baby, Bowie, who is now 8 months old, here, healthy, alive. I'm so grateful. And actually throughout that pregnancy, I was in communication with Dr. Kliman. I was trying to get my maternal fetal specialist to measure Bowie's placenta, which they did, but they were very hesitant to do so, which a lot of parents probably find. And I don't think they did it correctly, because they wouldn't really listen to me about how to do it correctly. So actually they told me his placenta was a normal size, but then he was born, and Dr. Kliman suggested that I make sure to send his placenta to the pathology at the hospital. And I did, and it came back that his placenta was also small. It was in the 3rd percentile. But luckily I had asked to be induced at 37 weeks because Hugo had died at 39. And Bowie lived, but I shudder to think what could have happened if I didn't induce at 37 weeks, knowing that his placenta was also small and likely would have gotten as small as Hugo's in terms of between body and placenta, because Bowie was a much bigger baby than Hugo anyway. So I'm just so grateful for Dr. Kliman and the answers that I got, because I was able to save my second baby's life. And obviously I wish that Hugo was here, and I'm pretty angry that this information has been out there for so long, but that it hasn't been given to all of the OBs, to everybody's, that the research hasn't been done. So that's why, I've met with senators and I'm working to help pass the Shine for Autumn Act, because without research, a lot of OBs and MFMs and people who work in the birth world aren't on board with measuring the placenta. I've had people say to me, we don't look at the placenta, we look at the baby. And as we all know from Dr. Kliman's research and everything he talks about, the baby and the placenta are the same. I mean, the placenta is the lifeblood of the baby, and without the placenta, the baby would not survive. So anyway, yeah, thanks for having me, and thank you, Dr. Kliman, for all your hard work.
Beautifully said, Jennica, and thank you so much for sharing with us about both Hugo and Bowie. I know, as a lost mom myself, that it's really hard. It's really hard to reopen those wounds, and I hope you know what a difference it makes for you to do that so selflessly, because your story and Hugo's story is empowering other parents to get better care than what we've received. So thank you for doing that.
I will also say, Jennica, your story is what inspires me. This is what drives me to help as many families as I possibly can. And until they carry me out of Yale in a box, I'm going to continue to work on this feverishly as best as I can to save as many babies as I possibly can. So thank you also for sharing your story.
So there were many larger systemic issues that you touched on, Jennica, in your story, and that sadly so many of us in the stillbirth community have been affected by. And I would like to go through each of those, but I want to first start with one of the easy questions. Harvey, in a current in a standard, or even a high risk pregnancy today in the United States, what about the placenta are doctors looking at typically?
They basically look at very little with the placenta. The few things that they do look at routinely, certainly starting at the 20-week anatomy scan, which is the largest, most detailed ultrasound, they will look for the location of the placenta. Clearly, it is a serious problem if the placenta is overlying the cervix, where the baby comes out. If the placenta is overlying the cervix, we call that placenta.
Nope, that would not be good.
That's not good. That's called placenta previa. And that's basically, if the placenta is really over the cervix, you have to deliver that baby by cesarean section. So that's, one thing they have to look at. So location of the placenta, they don't really look at the size of the placenta. I've heard different comments like, well, I just kind of guesstimate what it is. Maybe I look at the quality of the placenta to see if it's calcified or not, things like that. But most people simply, and remember, ultrasonographers, the technicians are actually doing these scans. They might also look at where the umbilical cord attaches to the placenta. So if it's right in the placenta, if it's at the edge of the placenta, or if it's in the membranes, there are different, potential risks for each of those. So that's about it, but they absolutely do not routinely measure the volume or the size of that placenta. That is not done.
And so that ended up being a critical factor in both Hugo and Bowie's pregnancies. And that's something that is overlooked. And so the research that you did that was published this week, Harvey, shows that for a lot of stillbirths, so as Jennica mentions, many parents, probably between a third to a half of parents still today who suffer a stillbirth, do not get clear answers as to what happened to their baby. So many of us are told, oh, you were healthy, baby was healthy. Sometimes these things just happen, as if a perfectly healthy person just drops dead. And that's okay. And we just shrug our shoulders and move on. Like, no. Why this is acceptable when it comes to our babies, I will never understand. But parents who go through this deserve answers. And as Jennica saw in her subsequent pregnancy, from many of us who have a stillbirth, on to recur. We know that research coming out of the UK from the Rainbow clinics there show that parents who've had a stillbirth are almost 5 times as likely to suffer another one. But if we understand what that causes and we are looking for it in subsequent pregnancies, and we are giving the extra monitoring that every baby deserves, and we are being proactive about their care, we can get those rates down to as good or better than the general population. And so that's why it's so critical to know the cause of the stillbirth. So Harvey, in the paper that you just published, what were you able to find looking at these previously unknown stillbirths? And how does that relate to what Jennica went through?
Sure. So I think it's a very important point to emphasize what you just said. These were cases sent to my clinic at Yale that were already unexplained. In other words, if there was an explanation, presumably they wouldn't need to send it to me. So they did not have an answer. So this is a special group. This is not looking across all pregnancies then, potentially, because there are some times where it is quite obvious. For example, if there is a knot in the umbilical cord and it's very tight and one side of the umbilical cord is red and swollen and the other side is white with no blood flow, that's a pretty clear reason. So something like that would not have been sent to me. So these are cases, and as Jennica pointed out, in our research of evaluating what had been done before, up to 50% of cases were unexplained. So this was a group of, we started off with about 1,500 unexplained pregnancy losses. We had to get rid of some because there was no material to look at or inadequate slides to look at. I forget the exact number. I think we got down to 1,256. And of those, about 70% were miscarriages, which are losses less than 20 weeks, and 30% were above 20 weeks were stillbirths. So in terms of the stillbirths, the main thing that we found is that in the whole population of 20 to 43 weeks, 33% were due to a small placenta. But I think what's even more impressive, if we just look at the third trimester, which starts at 26 weeks, then over 36% were due to a small placenta. And that is vastly the largest piece of the pie. I mean, the next one under that are cord accidents, which are a little less than 20%. But to have over 36% due to a small placenta, it just seems logical to me that since we know what the cause is in these cases, we should be doing something about it to prevent them. And there is something to do to prevent them. There's debate about the other causes. For example, cord accidents, can they be prevented? There are certainly people who feel that that's possible, but it's much more difficult because it's much more difficult to follow the umbilical cord because it's being moved all the time. If someone has a loss because of a cord accident, I definitely recommend in the next pregnancy that they ask their providers to at least take a quick look at the umbilical cord every time the patient is examined. I think that's reasonable. But the placenta is stable, it doesn't move really, and it's much easier to measure. So since that's the number one cause, it's easy to measure it. Why not put that on the list in the toolbox that is done routinely for patients? And if we're not going to do it for every patient, then minimally, I'd like to do it for these two groups. Those patients that have already had a loss because of a small placenta, and I view Jenica's second pregnancy as exactly one of those cases, right? That's why I worked with her and her providers to try to get estimated placental volume done. And I agree with her. I think that her early delivery saved her second son's life, period, right? It could have easily gone the same way. And I'll just mention one thing. People are a little confused of why it can so suddenly go bad. And one of the reasons is that the placenta is like the gas tank of a car. And a minute before the car runs out of gas, it actually runs perfectly fine. And then it just runs out of gas. And that's what happens with these small placentas. They're not insufficient. I don't like the term and I don't use it, placental insufficiency. In fact, these small placentas are super efficient. They are keeping these large babies alive inside of their mother's uteruses. And basically, there comes a point where this discrepancy of having a large baby, a large fetus, and a small placenta just becomes too much. It's like a rubber band that breaks. Part of the problem then in terms of the healthcare providers is that their attitude is, if it's a big baby, everything is fine. They don't realize that, in fact, a big baby is at much higher risk of having a stillbirth if they have a very small placenta. The only way to survive a small placenta, not that the fetus can consciously do this, is to be very small. If there's a small placenta and the fetus is also very small, it might get through. And it is much more likely to survive than a big baby with a small placenta. And so ironically, these large fetuses that are being followed by doctors are often considered to be low risk, completely normal, no problem. And so many of my patients exactly present like Jennica, right at term, right the last few days before delivery. That's when this difference stretches out like the rubber band, and that's when it breaks. And the time between everything's okay and everything is not okay, and you lose the baby, can be just a day, which is pretty much what Jennica just shared with us. So her story, sadly, is very typical of exactly how these losses happen.
Thank you, Harvey, for that really clear explanation. And absolutely, that is one of the most heartbreaking parts of a small placenta stillbirth in particular, is that so many of these are happening at the very, very end of pregnancy, not only in the third trimester, but at term, on your due date, after your due date. So many of these children had weeks during which they could have been delivered safely and not even needed a NICU stay in order to save their lives, if we had been looking more closely, instead of just assuming because it's a big baby that they are, or because they were on track, and everything looked good at 20 weeks, which is for many low risk pregnancies in the United States the last time you have a detailed ultrasound, that everything's going to continue to be fine for the next 4 months. I mean, it's just huge, so many missed opportunities, just resulting in the most devastating heartbreak that no family deserves to go through. And like Jennica said, so many of us carrying so many excruciating what ifs, so many regrets, so much undeserved guilt, because we find out later all the things that we could have done differently. And parents deserve to be empowered with that information before it happens to them, because we know, unfortunately, not every stillbirth will ever be preventable. Accidents happen. And like Harvey said, sometimes accidents happen very quickly in pregnancy. But every family who goes through this deserves to know that they and their provider did everything in their power to give their baby the best possible chance. And sadly, no stillbirth parents like Jennica or myself, and another 21,000 of us every year in this country, can say that today. And so I want to bring this back to the bigger picture here, and why so many of us, from PUSH and the Measure the Placenta team, actually the entire Measure the Placenta leadership team was there, and I think six of our 8 PUSH directors this week, along with our partners at Healthy Birthday, Debbie and the Shine Stars behind the Shine for Autumn Act. And there were 2 bills that we were advocating for with our members of Congress. They were both, bicameral, bipartisan. So they're introduced in both houses and active, and they have legislators from across the entire political spectrum. It's, I think, one thing we can all agree on in this country is we don't want healthy, loved, full-term babies to die. Every parent should be bringing their baby home from the hospital. So the 2 bills that we are advocating for, and I think, again, both Jenica's and my stories are great examples of, if these bills pass and are in place, how our stories could be different and how things will be different for future parents. The first is the Maternal and Child Health Stillbirth Prevention Bill. This is a very simple wording change to Title V of the Maternal and Child Health Act. So this is the federal dollars that are given to states to spend on anything having to do with helping mothers, babies, and children, pregnancy, all of that to be healthy and safe. And right now in the 30-page Title V Act, the word stillbirth is mentioned 0 times. And so where we run into an issue like this with this is that when we have tools like Count the Kicks. So another organization that we work really closely with is Healthy Birthday, which is a national nonprofit behind the Count the Kicks public health campaign for fetal movement education. There's also a free app. There's materials for doctors and patients. And as Harvey mentioned, when a baby is struggling from a small placenta or like in my case, cord compression leading to fetal maternal hemorrhage, or could be a variety of other factors in there. Sometimes things like preeclampsia, partial placental abruption. There's so many things that could go wrong in a pregnancy. And for many of them, the only warning that parents will get that a birthing parent will notice is a change in their baby's movements. And, the vast majority of parents in this country are not being educated about what is normal fetal movement, how to learn what's normal for you and your baby, because there is no set standard. 10 kicks in 2 hours is a disproven old standard, and what's important to know is what is normal for you and your baby. And most importantly, to know that if you notice a change, you must speak up immediately. As Harvey said, sometimes you have only hours, maybe a day, if something is going on, to make sure that you and your baby get help, and it could save both your child's and your own life. And so it's absolutely critical to always take it seriously and speak up. Thankfully, 99 times out of 100, it will be a false alarm, right? You go to the hospital, they will check you out and say, oh, I guess baby must just have been sleepy, or, sometimes we all have off days, right? So it's never something to panic about, but it is always something to take seriously, because if you happen to be like Jennica or I, that 1 out of 100 where there is something going wrong, there's nothing that you can do at home to help. You must be at a hospital where you can get proper monitoring and be delivered. And so the Count the Kicks program is designed to help empower parents with this information, give them a free app in many languages, and make sure, and also really importantly, educate providers, so that when a parent calls in reporting a change in their baby's movements, they're saying, yes, you're doing the right thing by paying attention. You're doing the right thing by speaking up. Please come in now so we can check you out and make sure that you and your baby are safe. And so to implement that program at a state level typically costs a few $1,000s. It's not expensive. There's plenty of money in the Title V budgets at most states to implement this across the state. But when a parent advocate like me or Jennica goes to their Title V administrator at the State Department of Health and says, hey, do you know this program exists? We should really be doing this for all the parents in our state. Often they will go look at the Title V Act, and when they don't see the word stillbirth there, they're like, I don't know if I can spend the money for this. And they actually can. But since it doesn't say that explicitly anywhere, this causes a barrier to implementing stillbirth prevention tools. So that's the first bill, Title V, Maternal and Child Health Stillbirth Prevention Act. The second bill, which we've mentioned a couple of times tonight, is the Shine for Autumn Act. And Shine is, this was created in honor of Autumn Joy, who is our friend Debbie Haynes' daughter. And Debbie has been fighting for a decade for better stillbirth research, education, prevention, and especially data collection. And so the Shine for Autumn Act is a pretty comprehensive package, which will address a whole host of issues, including the fact that so many parents are not getting answers after they've had a loss. The fact that when we do get answers, for example, when people like Jennica and I did the same as to how I got answers about my daughter's stillbirth, send their slides to Dr. Kliman at Yale or to other placental pathologists, and they come back and we find out finally what is wrong, what actually occurred, that the databases can be updated. Because right now, a child's fetal death certificate is filled out within 48 hours after the birth. There's not been an autopsy completed. There has not been a placental review. Genetic testing is not complete. We don't have any information. And so in many cases, a fetal death certificate will list as a cause of death either unknown or some complete nonsense, like on my daughter's certificate where it says intrauterine fetal demise, which is simply the medical term for a stillbirth. So she died because she's dead. That is not helpful to anybody who's trying to do research on the cause of a baby's stillbirth. So not only will it standardize the way that provide funding and standards for the way that fetal death certificates are filled out and the way stillbirths are reported up through the states to the federal level to make sure that we have good data for our researchers. It will create a mechanism for updating them later to make sure that they're actually accurate. And it will train more perinatal pathologists like Harvey to actually perform these autopsies and placental reviews, because the problem is there's literally even if we had, if insurance covered it for everyone, if we made sure that every parent was given this option, we don't have enough qualified perinatal pathologists in this country to actually review every stillbirth. So we need to train more, and the Sign for Automatic will do that. And then finally, also, we'll provide more funding towards education and awareness, because again, parents can't protect themselves against a risk that we don't know exists. And so these two bills are really, really critical. And again, Title V funding could go towards something like implementing estimated placental volume at the state level, and making sure that providers are educated about that and have that tool as one of the tools in their toolbox. So lots of different things can come out of these. It's not going to fix, nothing. There's no silver bullet to end preventable stillbirth, but these are two really huge, very important and critical first steps towards finally moving the needle in this country. And so we would ask all of you guys watching this to please contact your representatives and let them know that you're in support of this, and that you would love for them to co-sponsor these bills and to vote yes on them when they come up. So we will drop in the chat and Facebook the link to do that. I think actually maybe somebody might have already, but I will put that in again. But in the meantime, there was one question in the Facebook chat that Harvey, that was very relevant to what we were talking about. Let me just pull it up really quick. So Selena asks, how long do hospitals keep placenta slides for after a loss? So Selena lost her daughter Amelia in February, and she's concerned it might be too late to get her slides.
Sure. So let me address that. First of all, I'm so sorry for your loss, and I'm glad that you're here. And please email me, and we will be able to take care of this. So the standard procedure, once a placenta gets sent to the pathology department, is that it's weighed, it's measured, it's described, it's cut up sort of like a piece of bread. We call it bread loafing with a knife. And then small pieces are taken and put into plastic little holders, and then pieces of tissue are embedded in a wax block. So it's like looks like a brownie, but it's made of paraffin wax. Now, those paraffin blocks at Yale, for example, we have them back to 1905. So they're saved indefinitely. And there are many large medical centers like Cornell and Columbia and NYU and places like that, that of course will save them indefinitely. Even if it's not a large medical center, usually they're saved for 10 years. So February is nothing. That's not an issue whatsoever. And the slides are, again, saved for a long time. So I had, for example, a case of one of my Yale undergraduates who thought she was a twin, and she thought that she had somehow damaged her brother, who came out quite, with the serious problems. And she literally believed that she had caused this as a fetus. I know it's irrational, but she was 22 years old, and we got the slides from her placenta from Cornell 22 years later. So we can do this many, many years later. So if it's within a few years or even 5 or 10, it's feasible to do it. So basically, email me, or I don't know, Samantha, if you can put the link to the site on the Yale website. I have an assistant, Kristen, who, as Jennica pointed out, will help any lost family get those slides. You do not have to call the institution. We simply need a signed release from you, from the mother, the date of your delivery, your birthday, the name of the hospital. Once we have that signed, we will go to that institution and say, we have permission to get recuts from those wax blocks so we can look at the slides from the placenta. And we are able to figure out, as we just published, literally 99% of the time in stillbirths, we can figure out the cause of the loss.
Thank you, Harvey. That's incredible. And again, such a huge comfort for so many of us. For those of you listening, I was told after my daughter's 39-week stillbirth, 2 days before her due date, that because I was healthy and she appeared healthy, that by process of elimination, it must have been an acute cord accident, even though there wasn't clear evidence to support that. And 6.5 years later, I randomly sat next to Harvey at a stillbirth conference. He introduced himself and I introduced myself, and he said, do you know what caused your daughter's stillbirth? And I said, I think so. He's like, do you want to know for sure? And I said, yeah. And I was able, 6.5 years later, Kristen in his office called up my hospital, got the slides sent over, and within a matter of weeks, I learned that she did die of a cord accident, but it was not an acute one. It was she had a short, thin hypocoiled umbilical cord, which was prone to compression. And so she suffered through hundreds of episodes of cord compression over the last 2.5 weeks of her life, which is exactly the same time that I noticed a change in her movements, reported it to my medical care team at 3 separate appointments, and unfortunately received the what we now know to be inaccurate myths about babies running out of room and slowing down. And through each of those cord compression episodes, the pressure would build up and the blood would burst out, and she actually bled out slowly over time into her placenta. And again, this was starting around 37 weeks when she was full term. Could have been delivered at any point if we had been looking a little bit more closely. And so again, this is why we at Push and Measure the Placenta are advocating so strongly for improved changes to care and ensuring that parents know the risks, because I did not know that my healthy baby would die days before the end of her quote unquote textbook pregnancy. And unless you know that that's a possibility, you don't know how hard you need to advocate, right? Things are very different for me and Jennica in our subsequent pregnancies. And we unfortunately, and our thousands of other mothers in the stillbirth community, learned so many of the lessons the hard way, and we don't ever want to see another parent go through what we've been through. So thank you, Harvey, for all you do. And yeah, we really want to see the Shine for Automatics pass, so we can create a whole new generation of Harveys out there to make sure that every parent gets the answers they deserve. We are getting some other great questions from the Facebook chat. Lisa is asking if placental issues tend to be hereditary. Her daughter was born at 29 weeks, 2 pounds. She had preeclampsia, and they just had her sweet Lily in December. I believe this is someone who has spoken to you, Dr. Kliman. Lily was stillborn, and she was wondering if the placenta was potentially connected to her preeclampsia, or if there's any correlation, or if this is something that she should be looking out for in future pregnancies.
So the answers are yes, yes, and yes. Number one, there is a large genetic component to small placentas. In fact, the number one reason for a small placenta, the number one cause of stillbirth is a small placenta, and the number one reason for a small placenta is an intrinsic genetic issue with the placenta. And the placenta, just to remind people, is part of the fetus, part of the baby. You can think of the placenta as the root system of a tree. So if you look at a tree outside in your backyard, the root system under the ground is as large as the tree is above the ground. And that's the same thing with the placenta. So it's not mom's placenta, it is the baby's placenta, and it is the support system for the fetus while it's inside the uterus. And there is no other support system. That's it. It's like, Apollo 13 out between the moon and the earth. There is nothing else to support those 3 people in that capsule. Likewise, for the fetus, there is nothing else that will support that fetus in the uterus except for its placenta. So yes, there is a genetic component. Yes, these things can recur. But that's why, without going through all the details, and certainly please look at the paper we publish if you're interested in more details, that's why it's so important to get the cause, right? In general, how can you act on anything? How can you figure out what the future will be? How can you figure out what you need to be looking for if you don't know why the first loss occurred? And we also showed in that paper that once somebody has a loss, if they have another loss, it is most frequently for the same reason, right? It is not random different causes. So we might as well figure out the first loss, what's going on. And again, Jennica's story is very typical. I have so many patients who've had a loss, then in their second subsequent pregnancy, they survive, but only because they were, either more vigilant, demanded an earlier delivery. But, looking at the placenta, the same problem was there, and it was just sort of waiting to occur, right? So that's not surprising. So that's why it's important to look at that first loss and figure out what's going on. The preeclampsia piece, I'll just say this, is that preeclampsia is a clinical syndrome where the placenta basically says, I don't have enough blood coming into me, I'm not happy, and I'm going to make the mother who is supplying blood to me increase the blood flow by making her hypertensive. So that's the clinical syndrome that we see. It is the placenta creates preeclampsia. That's the source of preeclampsia. So that's not surprising. I saw one other question in the chat that I think I'll jump on because I think it's really important, and that is COVID. I know we're want to not think about COVID anymore. I get that. And I understand we want to go out and not wear masks and not be concerned. But I've been very troubled to see a significant number of patients sending me their stillbirth cases, and the reason for the loss is because of COVID. Now, let's just review a few facts about this. One, most women who are fully vaccinated, who do get COVID during their pregnancy, will not have any problems. So I want everybody thinking out there, and if they're pregnant and they're thinking about being exposed, luckily, most women who get COVID with the new variants that are out there, which are very contagious, even if they're fully vaccinated, will have no problem whatsoever. However, there is a subset. We don't understand why. We don't understand what's different about those pregnancies, that even when they're vaccinated, this subsequent COVID infection, it could even be in the first trimester, will somehow affect the placenta and damage it to the point that it becomes stillbirth. So this does happen. We're investigating this literally just today. I was working on this project. So we're trying to figure it out. We're trying to work with the experts at Yale who are really world-renowned experts in COVID. So I would just say two things for people listening to this message. One is, without question, you have to be vaccinated before you get pregnant, right? There is just no question. If you're not vaccinated, and you do get COVID, and it does infect the placenta, which is actually, the virus loves to go to the placenta, that will lead to a loss. It's a very high frequency of losses if the placenta is infected. So please, please get vaccinated. Whatever concerns you have, having a loss is much worse than whatever concerns you might have. That's number one. Number two, and I don't want to generate a whole bunch of paranoia here, but I would say this: if you're pregnant and fully vaccinated, at least consider yourself at a higher risk. Put yourself in the category of an older person, right? Someone with asthma, somebody over 65, those categories that we say those people should be more careful. Don't go to a large music concert crowded in with, 1,000 people around you. I don't think that's a good idea. Just try to, you don't have to hibernate in your home, but if you do go outside, if you do go shopping or whatever, wear a mask. I was just at an event last night. There are a lot of people. There's still people wearing masks. It's okay. We're not going to make fun of you. And who cares what people think about you if you're doing something to save your baby's life? So please consider, at least if you're pregnant, even if you're vaccinated, to be cautious about COVID. It's still out there. These variants are out there. We don't have the newest booster yet. So I still think that there is some level of risk out there for COVID.
Thank you for sharing that, Dr. Kliman. I think, as you said, none of us want to be thinking about this anymore, but if you are pregnant, you are definitely considered one of those high-risk groups, and worth taking extra precautions. And you're not alone. We're starting to see a lot more people putting masks on now that it's fall and we're starting to go indoors again, and we're starting to see, spikes in certain areas. So it certainly never hurts to take those extra precautions, for sure. So before we wrap up tonight, I know we've talked a lot about stillbirth, since that is our focus at Push for Empowered Pregnancy, stillbirth prevention, and Measure the Placenta. But I do want to kind of broaden the picture a little bit and ask you, Dr. Harvey, what you learned about miscarriages from this most recent study? Because I think you were mentioning earlier that there are 1 million pregnancies are diagnosed as miscarriage every year in this country. So what were you able to learn about the placenta in those losses and what that means for parents who might have experienced one or more miscarriages?
Sure, I'd be happy to share that. So putting the big picture, there are 5 million pregnancies a year in our country, and 1 million end in a pregnancy loss. That's 20%. So if you just look statistically, 20% of all pregnancies will end in a loss. Now, many of these are in the first trimester. Some of these, a good proportion, might simply be such an early pregnancy that is before the woman even went for their first ultrasound, and it is they pass it home as a heavy menstrual period, for example. But there's still, emotionally, I'm not going to sit here and try to judge the different emotions. I will say with my many, many patients I take care of, either with first trimester losses, second and third, from the point of view of the women carrying these pregnancies, it is still devastating. They feel that they've lost their baby. They're very upset. There are feelings of guilt, especially when it's recurrent. And this is definitely, these are the patients I take care of with recurrent pregnancy loss. They feel always that there's something wrong with them, right? So it's not that they did something because it's so early that you can't really do anything, but they feel there must be something wrong with me. I'm a failure as a mother. I can't make babies. There's something wrong with me. So what we found is almost 90% of these early losses, less than 20 weeks, are due to an intrinsic genetic issue. It shows up as the placenta is abnormally folded the way it looks. And that is a marker for something that is genetically abnormal in the placenta and presumably in the attached embryo in fetus. Now, there are other causes, but they're only 2 to 3 to 4% are due to clotting disorders or immunologic reasons. So it's not that it's zero, but the problem is, and I understand doctors are trying to help patients, but I think, again, it's another example. If you simply blindly treat somebody with a loss with a protocol like blood thinners, like Lovenox is a common one that's used. It's a heparin that basically prevents clotting. Do problems with clotting lead to early losses? Yes, 1% of the time. So why would we treat 99% of all the loss patients with something that only 1% need it? How do you find out why there was a loss? You look at it under the microscope, which goes back to what we've been saying throughout. You first have to make the diagnosis. So if, for example, in the typical patient, and I don't know if you have time, Samantha, to put this up, but Soleil, my patient from Iceland, her story on my website, if you could share that. She is a classic example. She had 7 losses, but has 4 children now. And during those 7 losses, she was always feeling that there was something wrong with her. When I first met her and she was devastated and didn't know what to do, I said, let's first figure out why you're having these losses. When I looked at the placentas from the losses, they were all genetic. I said, listen, you don't need any treatment. There's nothing wrong with you. This is a 50-50, flipping of the coin chance of having a loss. And her statistics of 7 losses and 4 children is very typical of families like this. And once she understood emotionally that it wasn't her fault, there was no treatment that was necessary, but she understood she had to be prepared emotionally for another loss, she prepared herself and tried again. And then she had more children. So this is typically what I say to these couples. So I'm a doctor who's not selling anything. There's no therapy for these, families. I basically say to them, I'm not denying it's not emotionally difficult for you. I understand it is, but there's nothing wrong with you. You don't need any treatment. Simply try again. And ironically, many of these couples are very fertile, right? They can get pregnant easily. And so that's a little bit of a gift because we have another whole subset, not talking tonight, of couples who can't even get pregnant from the very beginning. That's not what these patients are. They're very fertile and they have repeated losses. And so I tell them, just try again. It's not your fault.
Thank you, Harvey. I mean, I think, like you said, so many mothers and parents blame themselves when any type of loss happens. And I think it's particularly hard for parents who have early miscarriages and recurrent ones, because, you know, what we see so often is, you know, most parents are just said, oh, well, this kind of thing happens, just try again. And, you know, their insurance won't even cover investigating these types of losses to see if there's anything that can be done, or if it is just this common case where sometimes you just have to keep rolling the dice, you know, until you've had 3 or more. And by that point, the trauma is so terrible. So what advice do you have to parents who've had a miscarriage, maybe 1 or 2, and they haven't reached a point yet where, you know, the medical system typically is ready to look at them? What can they do to get better answers and find out if they are a patient like Soleil?
So first of all, I myself do not put that number on patients' losses. Even the first loss is upsetting. And the good news about payment is, because we get so many of these, and again, Kristen and the system at Yale at least helps the patients figure out what their insurance covers. Virtually all the patients are covered by their insurance for having this review. So only a small percentage need to pay out of pocket, which is a good thing. So I feel good about that. That's number one. And frankly, I would just say, send me the loss or have someone look at it, even if it's the first one. Now, there is one issue that I want to bring up here, which is realistic and important, and that is the following. The safest way for a woman to have a first trimester loss in terms of passing the tissue is to have a medical treatment, which we stimulate the contractions of the uterus and they pass this at home. It's not necessarily the most pleasant thing. It can be painful, but from the point of view of preserving their uterus, that is the safest thing. To do a dilation and curettage, where we open up and go into the uterus and actually pull out the tissue that's in the uterus, does have some risk. So I don't want to suggest that just blindly, but, and maybe this is the dividing line between 1 loss and 2 and 3 and 4. At some point, the only way to figure out what's going on is to actually get that tissue. And so one, looking at it under the microscope. And also I have a lot of recurrent pregnancy loss patients now. Once they're my patient, they're always my patient. And they call me, I'm the first one they call and say, I'm sadly having another loss at 8 weeks. We get them to send that to us overnight by FedEx. We then take fresh placental tissue and we enroll them in a study that the NIH pays for, where we do what's called whole genomic sequencing, where we literally look at every single DNA code, which are 6 billion of them, to try to figure out why they had their losses. So that's something that we offer. That's on my website also, if people go to it. So again, the bottom line is this: I just open my doors to anybody who's had 1 loss, more than 1 loss, anytime during their pregnancy. Just email me and Kristen and I will figure out what is the best pathway, can we get your insurance to pay for it, and what is the best way to deal with your each individual case.
Thank you so much, Harvey.
Of
Jennica,
course.
are there any final words that you would like to leave us with as a parent in this space, and what you've learned and what you wish somebody maybe had told you before your pregnancy with Hugo?
I mean, I think we covered so much of it, but really it's the same things you've already talked about, Samantha. It's count the kicks, you know, go in, even if your doctors are telling you the wrong thing, just if your intuition is telling you something is wrong, just go in and make sure somebody looks at you and don't leave until you're satisfied. And I just wish somebody had told me all of that before Hugo. I wish I even knew that stillbirth could happen to me before it did. I think a lot of us feel that way. So, and yeah, please don't hesitate to reach out to Dr. Kliman and find out what happened. I know it can be scary to find out what happened, and some people don't want to know. But I will say it was so important for me, and I know my partner didn't want to at first, and he's so glad that we did. So
yes, it is. It is scary to look for answers when it feels so much like the only possible answer could be is you, right?
right.
But I think that, I know for me, it was a huge weight off my shoulders to learn that what the actual cause of my daughter's death was, and that I did not do anything wrong. This
And I
is,
will say really quickly too, actually talking to you, Dr. Kliman, my partner and I both felt like we got to know our son better. So that was kind of a nice added bonus of finding out for us, is that I felt like we got to know his personality somehow better by finding out. It was, I don't know, that might sound weird, but talking about him on the Zoom for 2 hours or however long it was great, because we miss him so much. So
beautiful. Thank you so much, Jennica. Harvey, thank you so much for all you and Kristen and the amazing team at Yale do. Again, we're really excited that this research is available out there for anyone who's interested to learn more. Again, we dropped the links to all of this in the chat on the Facebook page. We will be reposting this on our Push YouTube page, and to Measure the Placenta and Push's Instagram's accounts will have additional information there as well. So please don't hesitate to reach out to us through any of those channels. Again, Harvey's email is harvey.kliman@yale.edu. That is in the chat for anybody who wants to contact him directly. Harvey, what else? Anything else you want to add?
No, I just want to again express my deepest condolences for anybody who's had a loss. I want to thank the brave, mothers that you just heard tonight, Samantha and Jennica, and all of my patients. Again, my personal goal is to help as many families as I possibly can. And I hope the Shine for Automac works, because I'm prepared to teach another generation of people how to do this. So I'm ready, willing, and able to help. And so let's all together work together to prevent as many stillbirths as we possibly can.
Yes, that's what we always say, right? United we push. Thank you all so much. And yes, remember to go to bit.ly/stopstillbirth to ask your representatives to support the recent bills in Congress, and to make sure that we continue to have National Stillbirth Prevention Day every year until we finally start to see those rates declining the way they need to be. So thank you all so much for joining us, and we will talk to you all soon.